Today's speaker is coming to us from Boston University, and we're lucky to have Dr. Pablo Buitron de la Vega with us, and he's going to be talking about exploring the potential of virtual reality in health professional education. So before I tell you a little bit more about Dr. Buitron de la Vega, I was wondering if we can do our little poll and get an idea of the demographics of today's meeting. Okay, super. So I think we mostly are faculty here today. Thanks for joining. So just to tell you a little bit about Dr. Buitron de la Vega, he is a general internist and preventative medicine physician with a long-standing interest in healthcare education and the impact of patients' attitudes, health beliefs, and social determinants of health. He provides clinical care to a majority of Hispanic patients and underserved population in healthcare. He is also the program director of the Chobanian and Avedisian School of Medicine, which I just found out was formerly the Boston University School of Medicine, and preventative medicine residency director and an assistant professor of medicine. Dr. Buitron de la Vega is also the clinical lead for Boston Medical Center's Thrive, a program that systematically screens patients for social determinants of health and refers them to resources when requested. Additionally, he is passionate about the use of emerging educational technologies, including virtual worlds, virtual reality, and mind mapping, to develop interdisciplinary experiences to teach about health equity and social determinants of health. So with that said, I'm going to turn it over to Dr. Buitron de la Vega.
Excellent. Thank you so much. I'm really excited to be here to talk to you a little bit about the work that I've been doing with emerging learning technologies. So I'm gonna share my screen. Okay. Screen. Okay. So we are really going to be talking about different thoughts and ideas and cases in terms of how we can use emerging learning technologies, specifically virtual reality in health professional education. I have no conflicts of interest in relation to this presentation, but I do want to acknowledge the really big team that we had to be able to do a lot of these things, the partnerships that we had, mainly from the Boston University School of Social Work, from Boston Medical Center, that's our healthcare institution, and from the Boston University Digital Learning and Innovation Department that funds a lot of these things, and a lot of the faculty that's really behind this. It's really massive effort to be able to do what I'm gonna show you. So during the time that we'll have together, first we'll talk a little bit about digital education basic principles, to kind of take a big picture idea of when I'm talking about virtual reality, what am I talking about? What is that? What's the difference between that and augmented reality and all other things in terms of definition? Then we're gonna go and talk a little bit more about virtual reality environments and give you then some case studies in terms of how you can use virtual reality to teach equity, social determinants of health, interprofessional education, to teach about poverty. And then I'll share other examples from other institutions with the hope that it will give you ideas, give you thoughts about things that you can do. So to start, it's important to think about the cognitive theory of multimedia learning. This is adapted from Mayer's model of multimedia learning. So mainly what this is saying is that you have information that you want to present. Either it's a case, either is any learning experience that you want to present, you're going to present information. Then that goes to your sensory, so your eyes, your your kinetics, your ears are going to take that and are going to pass it to the working memory. So depending on how you're presenting that information, your working memory is going to either work really, really hard to code it into your long-term memory, into these schemas in your brain that are saving and storing the information, or you're going to have like a much easier time with your working memory and coding. So it's important to keep this in mind, because the way that you present the information is a choice that you have in terms of this. So how do we usually deliver information, especially thinking about healthcare professional education? So there's different ways of delivering educational information. One is the traditional way. So it's mainly non-educational materials like a textbook or like a model or your in-person teaching. So those are what we call the traditional ways of delivering the information. Then you have digital information or digital education that entails a lot of different delivery tools. One is what it's called massive open online courses, the MOOCs. So it's mainly you primarily accessing an online learning module through a desktop, through a laptop to learn about something. Then you have mobile education that is mainly accessing a learning or accessing a module through your phone or through a tablet. And these are mainly learning experiences that are designed to access through mainly a phone or a tablet. And then you have virtual reality environments, or virtual reality as digital means. So I would like to ask you if you can type in the chat, what comes to mind when you hear about virtual reality? What are the first things that come to mind, if you can put it in the chat? Yeah, one is like how you access it through Google's headsets. Yes, games, surgical simulation, games. Yep. Immersive versus not immersive, making it fun, dizziness. Yeah, and we'll talk about the quote unquote side effects of VR. Programming that I don't know how to do. Yeah, and a disclosure I have to make: before I went to med school, I was thinking about developing video games. So I always thought that at some point in my career I was going to be able to do the two things. So I'm excited that I'm being able to do that now. Excellent. So virtual reality, when we talked about virtual reality, is mainly we're thinking about that you're creating a three-dimensional world that replaces the real world. So in this case, for example, in the picture, you can see a picture where we're creating this new world that is a hospital setting. It's replacing your world. And you can access this either through a headset or just through a desktop, but the main thing is that it's a three-dimensional environment that you can access it in different ways. It really gives you a sense of depth, a sense of immersion. That's why it's like virtual reality. Now, when we think about augmented reality, the difference is that you're not creating a new world, you're enhancing the real world. For example, you're using Google's and you're seeing a model on top of your table. Or I don't know if you guys have seen about the games of Pokemon, that you have Pokemon Go and you're going around the city finding different things. You're augmenting to a reality that already exists. And for example, these use a lot in anatomy. You're like, everyone is in one room, everyone is wearing a headset, and you're seeing a model in the classroom through the headsets where you're seeing different things. That's augmented reality. And then you have what's called digital psychomotor skill training. Just think about like you're practicing your ACLS, your BLS, and you're doing these things. What is interesting about is that while we try to classify this in these five different ways of information delivery, most of the time what we're doing is a blended type of digital education, because technically you can do a virtual reality develop a virtual reality experience that can be accessed through a mobile phone, or you can create a MOOC that can be accessed by virtual reality, or you can create a patient that can be accessed through mobile education or virtual reality or augmented reality. So it's a mix of all these things. So that's why, and the reason why I'm telling you this is because when we think about the information delivery, it's important to think that you want to use this tool to enhance your current learning, not to replace it. It's to enhance what you're already doing. So it's not about the tool, it's about how you use principles of learning to use these tools. And I'm going to talk a little bit about that. For example, a lot of you said games in the chat. And if you think about most of VR that is used in healthcare education, it actually doesn't use game-based learning. That's one of the things that I'm really interested about, is how can we apply games-based learning when using about virtual reality? Because most of the times, if you're creating like for example, a surgical model to train, it's mainly an environment where you're practicing, but gaming is different. Gaming is you're competing. Gaming is they're scoring you. Gaming is they're making it difficult for you. So gaming-based learning is not necessarily a type of information delivery, is a technique that you use with this. So having said that, let's talk about virtual reality environments. So virtual reality environments, as I mentioned, they're like these 3D generated, computer generated environments where you can access and be fully immersive in the experience. And in these virtual reality environments, you can have either an immersive environment or a non-immersive environment. And the main difference is that in the immersive environment here in the left, you're accessing this virtual world by using a headset. In this case, there's so many headsets out there. There's the Oculus, there's so many out there, but you're mainly accessing this virtual environment through a headset. But there's also the non-immersive version that you can actually be accessing exactly the same environment, this 3D virtual environment, but through your desktop. And that's in the right side. So those are the main difference between these two. So at a glance, if you think about virtual reality in health professional education, there's a lot of advantages and also challenges that we're going to discuss. The advantages is it's very immersive, and it really helps addressing Zoom fatigue, because you're taking a lot of these distractions that the students have. They have their phone, they have Zoom, they have like all these different things they're doing at the same time. If you put a headset and you take all of that out, you really help them immerse. There's high level of realism that is something, it's something great, but it's something that could be tricky as well, because we have this year of what we call the uncanny valley, that is mainly that virtual entities that closely resemble humans can trigger mental uneasiness for viewers. So if you as our medical students are experiencing this and it feels too real, can trigger a lot. So what we try to do is really prepare the students to make sure that they know what to do if that happens, but also inviting them to really connect, really participate, because these are things that are going to be exposed later on. So really trying to help them be in a safe space in this place. And that's what the virtual reality also gives you, a safe environment, especially if you're thinking about talking about equity, talking about racism, talking about these things, creating this, putting yourself in an avatar that is this fictional character that you take when you're in this environment, gives you that possibility of feeling safe, feeling that you have more control. You can have a variety of cases. Also, it's great for interdisciplinary learning, because as I'm going to talk to you about, if you want to collaborate with the School of Social Work and they're like really far, what do you do? Yes, you can use Zoom, but is that going to be enough to engage your students? That's when you have to make a decision if you want to use some of these things. Some of the challenges, there's too many vendors, and it's very hard to collaborate with the different VR vendors, because remember, somebody's creating an environment, a game for you, and it's challenging. It takes a lot of time and a lot of effort. So it's important to be strategic there. There's insufficient data in terms of return of investment. And while there's insufficient data, I want you to think about many years ago when either PowerPoint and Microsoft Word were put out there. You never saw like a randomized control trial of Microsoft Word versus the paper, or PowerPoint versus something else. Why was that? Because these are mainly tools to enhance what you're doing. So it doesn't really make a lot of sense to compare virtual reality versus non-virtual reality. The idea is to enhance what you're doing and compare different ways of using it in different spaces with different learners, with different theories of how you are providing these different things. High cost is another problem, but that's getting better because now headsets are much cheaper, and there's so many vendors that it's much better to do here. And scalability implications, if you want to do this for 100 students, you have to get a lot of headsets as well. So that's one of the things. So we're going to go through some case studies, and the first one will be how we use a virtual reality environment or a 3D virtual world to teach about poverty. So we'll talk a little bit about background in terms of why we started doing this, some of the objectives that we were trying to get, the design of the virtual world, the outcomes, some feasibility things that we found, and some discussion in terms of this first case. So as a background, what we're teaching in the med school, we know that poverty is associated with inequities, and we know that medical students receive insufficient training for this. So our goal was really thinking about how can we expose them in a safe way so that they can understand what are the challenges that communities experiencing poverty face. And there, at that point, we knew that there were really good poverty simulations that, for example, one is in the Central Kentucky Community Action Council. That is a in-person community action poverty simulation. So in that case, when we had this idea, it's like, okay, we want them to go through this poverty simulation. Can we do this in person? What is the way that we're going to deliver that information? And we went back to this diagram that I told you. So we thought about, okay, why don't we do it in a traditional way? But we didn't have like the space. We didn't have the resources to put 160 medical students that we have in one room, and we didn't have enough faculty to do that either. So that's when the idea came, okay, let's think about maybe doing something digital. Can we do it through mobile education? Can we do it virtual reality? And our thought was, well, we can create a virtual environment that resembles Boston, that resembles the communities, and they can access there. Do we need them to access through a headset? Do we need them to access through a desktop? In this case, mainly what we wanted them is to experience some of the challenges of reaching out to different organizations. So we felt that we didn't need to have a headset. And I'll explain to you what we did. So our objective was to develop a training environment in which first-year medical students could experience the challenges that people in poverty face and review resources available to help them. And that's how we created the virtual poverty simulation. So how did we design this? So we partnered with a company that's called Beardway, and we created this virtual world. Here you can see different things in the picture. You can see that we created the family homes in the left. So all the students will be placed in these family homes. Then we'll have different community organizations that were in this virtual environment. You had an education, you had a housing, you had the healthcare, you had the workforce development, you had the food pantry. In healthcare is kind of the office where you will go get healthcare. You had a park here, and this was a computer simulated environment where the medical students will have an avatar, and this is a fictionalized computer representation of a person, and participated in different activities here. So this is what we created using this platform. So before they had this virtual poverty simulation, they received these two things. They received here in the left, this is your storyline. So they received the information about the patient. Who are you? So you were part of a family. So your role, your family, your storyline, your individual needs, and your family needs. And one thing that I want to mention here is that in the individual. Okay, can you guys hear me there?
Yes.
Okay.
Uh-huh.
So here we also included assets because we didn't want to just portray the social factors that are negative for the patients, but also then we did these 5 minute videos where we told you about the family. Then this was integrated in the first year of the curriculum of the medical students, and this was done in 3 different days. So each day we had different groups that would go through this simulation. This was the breakdown of the simulation. So they will start, everyone would use their computers. They will all be in the med school. They will go into their computer. They will access the Beardway, that's mainly the virtual world. And the first thing that they needed to do, they needed to find their family location. So they will go in their family, they will meet their family, and they will then get an orientation of the virtual space. It was key to set up this in a way that this was a serious game. this was that to consider that there might be a lot of students in this game that were actually experiencing this. So to make sure that framing in that way, so that they don't feel that we're making a game about poor people, but more it was an experience of what challenges, some of the challenges that could happen there. Then the first 5 minutes, the medical students will introduce their family member to the rest of the family. They will discuss their needs, they will plan out each task, and then that they needed to complete the upcoming week. And then they will go out to the environment. They will have 15 minutes to go to the different service agencies so that they can try to get help with food, try to get help with education, try to get help with all these different things. And it's a game that we designed that they could actually not win, so that they could actually experience what are the challenges that is not really easy to find this. They will go back to their homes and they will start planning for the next week. They will have the second simulated week, and then we'll have a debrief in terms of what are the things that they felt that were important here. The simulation was run using 8 separate virtual world sessions. Each of these sessions happen in a week, and each of the simulations require 5 faculty here. This is a picture of what it looked inside the family homes, if you see here in the left side. And I'm going to show you a video here of this is where the virtual environment. So if you see here, the student is looking for their family homes. These are the family homes that we created. So this is the Urbina home. So they are going in, and here they're going to see different things there that they can see. And one thing that I want to point out here, that even though this is a virtual world, we put some two-dimensional assets here too, so that they can remember what they needed to do. We put the brief list of activities. They could click the video to see their families and all these different things here that they could see. So this is the family home. Then this is inside one of the homes. If you see these, this is one of the areas where the student will go and ask for resources. And one thing that I want you to notice is that there's no ceiling here. There's not a lot of details here, because we also want, even though we want this to be somewhat realistic, if you put too many things there, if you put windows, if you could put the ceiling and everything, it can create too much cognitive load. So you want to limit the things there. You want to create a safe environment, but you don't want it to look too realistic, because if not, it takes out of the experience as well. So what did we find here? This was really a feasibility study. We did some pre and post surveys to just test our quality metrics, but what we found is the most interesting thing here is that medical students that did not have any experience either working with patients in poverty or experiencing poverty themselves reported the greatest sense of being there during the simulation, and were significantly more likely to report that the simulation added value to their training. And this is something that came out because while these were the perceptions of the students, it did feel short for the students that have experienced this. While many of them were saying things like, wow, this really resembles my own story, but I didn't know where I fit there. So we needed to do a better job, like making sure that they have their own role as well. In terms of knowledge and attitudes regarding poverty, these are pre and post survey, really just to test our things, but this is not the strongest tool to show impact on education here. But the main things that we found is that the medical students really felt that they should explore more about social needs, and they needed to connect patients to the different organizations that are out there. So what did we learn about this? We learned that it did have a positive impact on knowledge and attitude. We learned that it was engaging and safe environment. We also learned that we shouldn't call it a poverty simulation. I think that was very discriminatory for how we were calling this. So we've changed the name to call it a virtual world about challenges with social determinants of health. And that was one of the things that the students really requested. Some of the limitations is the outcomes. It was because there's so many things happening in terms of teaching about poverty in our school. longitudinally, it's really hard to know how much this had an impact there. But it was feasible to implement and integrate into the curriculum, and especially to the students that have never experienced this in the past, it was something really great for them to engage with. So that was the virtual world poverty simulation. Before I go to the next case, I would like to open this for any questions that the group has about this virtual world poverty simulation. You can either put it in the chat or just unmute.
I have a question.
Yes, go ahead.
So I'm just wondering if somebody is from that community, how did they take it? I heard you say that they didn't like the name of it, but how did you take it in terms, how did they take it in terms of the experience? Did they feel like it did justice to the experience, or what, it missed something? Just kind of wanted to get a sense of that.
Yeah, it was very interesting because I think that was one of the gaps of how we designed it, because the group that was designing this, well, we have lived experiences, we don't have the same lived experiences of our communities. So the cases, the review of the cases was very mixed. There were some students that were saying like, wow, this is exactly the way that my family had to struggle. And some others were saying like, you know, this is really falls short in terms of showing all the challenges. So it's a very mix. So that's why more than really changing the cases, I think is being more intentional in terms of how we introduce this and how we give a different role to the students that have experienced this in the past, and also like bringing patients from the community to give us their thoughts in terms of this, because I think in general, like in the projects that we have, we are switching from creating these things for the communities to creating these with the communities and paying for their time to help us creating these things. So those are kind of next steps for this, definitely.
Thank you.
We have another question from Dr. Roswell.
I just want a quick point of clarification. You said that you didn't want to put the roof or windows because it would make it too real and that would take away from the experience, because a lot of times we want to get that sense of realness. And so I'm just curious to why you would want to make it not as real. So I just want to elaborate on that just a little bit.
Yeah, thank you, Robert. That was my struggle because I knew that we could do that like at the beginning, and then I went to some of the evidence that shows that while you keep adding specific physical things in your virtual environment, your working memory makes a lot more effort to process everything. So, for example, let's say that right now your working memory is working 50% by being embedded in this room. If you add a window, if you add a picture, if you add the floor, if you add a computer, if you add, all that starts building up in your working memory. So it's much harder to do. Now you have to be careful, because also if you don't make it realistic enough, your working memory is also gonna have to work a lot in terms of like, where am I now? So it's a very fine line in terms of how much you put and how much not. For example, what we do want to do the next time is actually put the roof, because the not having a roof was distracting, but having other things in the room was actually good for them.
Thank you. We actually have two questions from Dr. Casara, and he's very involved in simulation. So the first question in the chat is, did you find that creating your own virtual world through the software, in contrast to using Second Life or some other more readily available software package, provided a greater benefit for your students? And then he had a second question about how students interacted with the characters in the virtual world and whether they did so in other ways, such as virtual social media, virtual newspaper, etc.
Yeah, the first question is it's something that we spend a lot of time, because actually that was our decision. Should we use Second Life? And for others in the Zoom, Second Life is mainly, think about it as a Facebook, but you have an actual avatar and you have a virtual world that you access using your desktop. And the good thing is that it's free, and you don't need to really pay, or you can build the thing yourself. The reason why we end up not using Second Life is because the desktop that we needed to function required a lot more power. And the other thing is that in terms of getting them into the actual virtual world, it was going to take us a lot more education to the students until they can get in. Now, having said that, I know that it has changed a lot. You know, Second Life keeps changing. It keeps getting easier to get in. But what we wanted is to kind of isolate this world from everything else. So that's why we end up deciding to use a Beerway and not Second Life. But can you create the same thing in Second Life? Yes, definitely. You can create the same thing in Second Life. And the other thing in terms of the students interacting with the characters in the virtual world, in other ways, the other things that we had, if I'm understanding your question correctly, the other things that we have in the virtual world, when they were in the virtual world in separate spaces, like let's say that the mother was in the education office and the father was in the food office, they could text themselves to try to see how things are going. So that's one of the ways that we're communicating. The other thing that I want to mention here is that their ability to choose their avatars we took it away from them. So the avatars were pre-made for them. And that was something that it was very tricky because at the same time that you want to portray the family as it is, you want to be careful in terms of not creating more stigma on the family. So we were really intentional in presenting the families and saying, okay, we have decided to include a Latinx family because these are the prevalence is higher in this Latinx community because of all the injustices that happen. So that's something that we had in mind and we kept in mind.
So I think there are 2 more questions. Would you prefer to take them now or save them?
No, now it's good. Yeah, now it's
Okay,
good.
sure.
I think
So
we're good on timing.
Okay.
Yes. So
Dr. Fernari? No,
Hi, can you hear me? Can you hear me?
Yes.
Yeah.
Good. I don't know. I'm not on my Mac, so I'm totally disoriented. I apologize. So everything with simulation, I wonder about the transfer to the real world, because it is exciting to learn this way. And I'm an educator and I love engagement and the excitement and all this. And I'm just wondering the complexity, even when we do mannequin simulation, how much goes back to the real world. So if we took these students who went through this whole simulation and then put them into a community rotation, how would we think about, did we really have the impact we wanted for the real world? Because that's where they're in a function. Yes, video games, all these games are great, but I'm just concerned, does it transfer to the
Yeah,
world?
and that's a great point. That's a great question, because one of the very dangerous things that can happen with this is replacing the actual in this case visiting the community
Right.
with things like this. So the idea is, where does this fit for our students? Was like, this is the first step of you understanding a little bit from a big picture where you're gonna go. But we also, part of the community, part of our curriculum is actually having them go to these organizations to understand. So it's like having them a better transition. But I completely agree with you. And unfortunately, I've seen that in other places where they're taking this and replacing all those in-person experiences completely. And I think personally that's wrong. I think it's how can you, like for me, the question was, how can I longitudinally spread these concepts about poverty through the whole curriculum in a lot of different ways? Because something is going to click. Maybe for somebody clicked during the virtual poverty simulation. For somebody was actually going to the actual community. So it's a lot of different ways of exposing them to this different information, so that something connects with them and they can understand and they can connect. Because one of the challenges that most of the medical students in general in the country come from families with a lot of privilege and power, and they've never experienced these things. So how can you start putting them in situations where they can start learning about these things? But yeah, I agree with you. I think and framing it like that too, like making sure that they understand that this is not the only thing that they're going to have in terms of exposure to the community.
Right. Okay. Thank you for agreeing with me. I appreciate it.
Yes.
One more question in the chat is, I noticed you use Powtoon. I don't know if I'm saying that right.
Yes, yes,
Okay,
yes.
to make the videos. Who were the faculty staff that created those videos, and how were they supported with the tech needed?
Yeah, so actually that was one of the things that there were four-year medical students that took that in, and so I am very familiar of using Powtoon. Powtoon is mainly a web-based platform that helps you create these animated videos. Actually, I was a little bit worried that they were not going to be able to do this because I didn't have the time to do this, but they all created these videos very easy and very fast.
Very easy.
It's very easy to use. Yeah, it's very easy to use.
Easy. It looks so fabulous that you think it's complicated, but we have videos on my app that I've created, which is another form of learning. And all the videos have been created on Powtoons, and it's amazing. Not that I did them, but somebody else I know did them, and they weren't that hard. So
Yes.
I agree with you on that. That's doable.
Yeah, definitely. The families, the family videos were a key thing is we wanted them to engage with the storyline, so that really helped.
Great, thank you for all your questions.
Excellent questions. Okay, so that was the virtual world poverty simulation. Now I'm gonna tell you about the virtual reality to teach health equity and social determinants of health and interprofessional education. So this is a team-based social determinant of health training for medical students, physician assistants, and social work students using an interprofessional virtual reality simulation. So similarly, I'll talk about like a little bit of why we wanted to do this, some of the methods that we use to study some of the results and next steps. In this case, thinking about the progression of our students. So at this point, this was more for second and third year medical students. So we have exposed them to what are the challenges of experiencing poverty. Now we wanted to give them skills of, okay, now how do we address this in a collaborative way? And we know that social work students have extensive training on this. So how can we put them together? And can we just put them together in Zoom? Should we use a VR environment? And that's the discussion that we had. Again, going back to this, can we do this in a traditional learning method when we can put everyone in the same room, do a case, and they can interact with each other? Unfortunately not. Our schools are very, very far in terms of distance, and we couldn't really figure out a way of doing this. So can we create an online learning module to do this? Yes, but we really wanted them to be in the same space, to interact, to learn about them. So we really wanted to create a virtual reality environment to be able to do this. And so we use a blended approach in this case. So we had, this was in the beginning of 2020, we had 15 participants, 5 medical students, 3 physician assistant students, and 5 social work students. The intervention had 2 pieces. One was a web video conference through Zoom that happened at the beginning of the week, where they learned about social determinants of health, health equity, team-based care, and they also learned about the virtual reality simulated learning environment that they were going to participate in. So we gave them some practice in terms of how to ask questions about social needs, how to collaborate with the social work. And then they had the virtual reality simulated learning experience later on during the week. And we evaluated the feasibility and the student perceptions about this with the use of focus groups. So after they received the Zoom, then this happened on a Thursday, where they all met through using the VR headsets. So the environment starts with a medical student wearing the headset. In this case, this was immersive, so they wear one of the Oculus. They wear the headset, and they went into this virtual environment that we mainly created a hospital room from Boston Medical Center. This was actually created with some pictures that I took from the actual room in the inpatient setting. Then the medical student had a tablet there with Thrive questions. Thrive are mainly the social determinant of health screener that we use in our institution. And the first role was to ask the patient about their social needs. This is a case of a patient that came with hypertensive emergency and heart failure that was really having trouble following the plan because of exposure to a lot of social needs. This is the observer view, so you can see that this patient is asking about these different things. And here I want to make a comment. If you see the patient has their own body, but the student also has only has their face and their hands. There's a lot of evidence that show that if you put all the body in the avatar for the students, that distracts a lot in terms of them, but you still want to keep the patient completely on their body, because that helps a little bit with realism. So after the medical student has asked all these different questions, all these different things in terms of the social needs, they will go to the huddle room to meet the social work student. So in the huddle room, the student will present the case, will do a case consultation with the social work student. And mainly they will both be discussing in terms of how are we going to be able to help this patient, how are we going to be able to address some of the needs collaboratively. Then they will both go back to the room. In this case, you're seeing a male patient because we had two different cases. And in this case, both students will be in the same room, and they will both be talking to the patient about different things. If you see here, one of the glitches that we have in the system is that we work a lot to try to make sure that the avatar faces were at the same level of the patient, but it was really hard in terms of technology. But at the end, we were able to make it, but that's one of the things that we were having some trouble there. So as a team, they gave all the resources to the patient, collaborated with the patient to develop a plan that will fit for the patient, and then they will have a debrief. In this case, the patient is role play by a faculty. You could change the voice of the patient so that they don't necessarily know who you are, but it was not enough to necessarily make the students not know who it was. And then they will have a debrief. We'll talk about different things there. So in terms of feasibility, we were able to run the 8 VR sessions, and we got some students' perceptions in the focus group and post surveys. So a lot of interesting things came out from this qualitative analysis. So the valuable aspect of the experience for the medical students was to learn what kinds of services the social workers provide, and having the opportunity to collaborate with other students. The medical students really appreciated how the social worker really has a much more in-depth knowledge in terms of how to ask these questions. For the social work students, the most important thing for their group is that they kind of found their power. They found their position in this, that they are really bringing a lot, because there's all this hierarchy between the physicians and the social workers. And if we can do this early, this can help breaking hierarchies. And they wanted to know more about how social work students are trained and how the different health professional students are trained. And as I mentioned before, for the social worker, as you see here in this quote, it's interesting seeing how my role was kind of important for the medical student, and then seeing how the role is actually strengthened through a role. So finding their position, finding their importance here. And this came in many times from the medical students. Just seeing and hearing how the social work student is asking the question was extremely helpful, so that then they can use the same approach. Some benefits of the immersion and connecting campuses, like they're physically away, but we were able to put them in the same room. It was important. Another theme was breaking down barriers, really realizing that we're all working the same team, that we can work together to change this culture of hierarchies. So in conclusion, we found that the VR can connect students across programmatic and geographic boundaries, and that VR really created a safe space where students can collaborate. And also the VR helps students appreciate the unique skills that each discipline brings to patient care. And based on this was implemented in 2020. So right now we're implementing the second pilot, and I want to show you a few videos of how the second pilot is going, because we've changed a few things there. Let me share my screen here. Okay, let's make sure that you're seeing my screen. Okay. Okay. So this is okay. So this is the conference room. If you see, we created a conference room where you have the students, the instructors. You're going to see that some avatars are still geometric figures because we're working with a vendor to make sure that everyone can create their avatar. So that's something that has been a limitation. So here, the two instructors are in the front. And first, we have a discussion. This is a patient. We did a pediatric case as a failure to thrive case. So in this case, we actually have 2 nutrition students, 5 medical students, and 2 social work students that are in the same place. And in this case, was really exciting for us that this is the first time that we were able to do it with everyone wearing their PR headsets from home. So they didn't have to even go to their schools. And we were always worried about this because of the Wi-Fi or the settings, but in order to run this, you need a Wi-Fi connection that can do Zoom. So everyone really had that capability there. And if you see that's the conference room. So they're talking about the case, they're thinking about different things, and then they go into the huddle room. So here in the huddle room, the social worker is talking with the other different students about how do they want to approach this. And because that's the other thing that we changed. If you remember the first simulation, we had the medical student go in first. But we wanted to really change the way that the students are thinking about interdisciplinary care. And while this is not something that they're usually doing in the inpatient care, this is what we want them to encourage them to do, and this is what we're hoping that is going to be in the future. So if you see they're like different, they're talking about how they're going to approach this in the different, when they go to see the patient. Then they go into the exam room, and this is the exam room. And there's a few interesting things that we were able to do here. So if you see the child is there, the parent is there, and now in this case, the parent can be role played by a faculty, but also the parent is going to be able to be an NPC. That's a non-playable character, mainly an artificial intelligent character that's going to respond with a technology that's very similar to ChatGPT. So we're going to be testing that in July. So so in this case, the medical student, the social work student, the nutrition student, the first role play, they're asking the patient like, okay, what's going on? What's the most important thing for you? They have the tablet with the Thrive screening. And this was much better than the first one where the medical student went first, then they came out, because this really pushed the 3 students in the huddle room to talk about things that sometimes they don't think about, like who's going to talk first, who's going to do what. And the other thing that we had, and this is where we use some gaming principles, is that each one, if you see here on top of the medical student, there's a microphone there. So they had like this almost baton function that they have to pass the baton before you can talk, or somebody else can request the baton to talk. And if you don't do that, the patient is not going to hear you. To trying to give them an idea of like, you have to be respectful of the time and you have to do these things. The other gaming piece that we added here is that while everyone is talking, the software is actually recording how much time you talk. So once they finish doing this, so they collaborated between them and everything. And then they go back to the conference room, and I don't have it here in the picture, but in this screen, you're going to see a breakdown in terms of percentages of time that each one was actually talking. So then you as an instructor don't have to say like, well, you were the medical student and you were talking like 90% of the time. They just look at the screen, and it's really an aha moment for them when the dynamics are not good. And then you get a score in terms of how well you did this, and then kind of that's the end of the first verse part of it. Then the second part is that they go back and they go back to Zoom, and they find resources for the patient using a directory that we have, and then they go back in and give resources to the patient. So that's the second simulation that we've done. I'm gonna pause there to answer any questions that people have about this virtual reality immersive simulation.
I actually just have a comment because we have been, I guess, sort of challenged by having an interprofessional experience for our early learners. So in the first 2 years of medical school, we've tried to run some interprofessional events, but it's been challenging to develop a clinical setting or scenario that's realistic and is fair in terms of participation for the different groups that are with us. So I actually find this very intriguing because I think it would be able to pull together all of the different healthcare providers in a single clinical setting, and they cannot actually need to be in the same room at the same time. And I think it actually would be very beneficial and something that we have been struggling with. So I actually like it a lot.
Yeah, because one of the challenges that we had is that the social work students, their education happens in the evenings, and the medical students, their education happens in the mornings. And at the beginning of this second pilot, we were having the students come to the medical school at 5 p.m. and they were just not happy. They were like, like, this doesn't work for me. I'm driving 40 minutes here. Why are you making us do this? And when we switched to like just giving the VR headset to the students, they'll go home and they can be there. It's evening, but they're there. It's safe. They don't have to go back, and they really appreciated that. And same thing with the nutrition students. They are in their rotations, their placements, because these second iterations for second-year medical students. But the social work students and the nutrition students are much more advanced, so they are in their clinical rotations and they have to do it later on. So those logistics are really important. But all the schools really needed something interprofessional, and we're all struggling to find ways of doing it. So the resources are high, but there's not much that we are doing. So this is a good option.
Thank you. I will open it up to other questions. So you could either raise your hand or put questions in the chat, and I'm happy to read them.
I don't know if you want to answer this one now or wait until the end of the presentation, but as I look at that and I think about, I see like a small group classroom and whatnot, I'm curious to hear what your thoughts are of, like 15, 10 years from now. What do you think classroom education looks like, clinical education looks like with respect? I mean, certainly I appreciate and think, the examples you're showing us are amazing and in many ways augment pieces of curricula that currently people have difficulty incorporating. But I'm curious also how you think about current pieces of curricula that we include and what they might look like with this kind of overlay.
Yeah, so I think in the some things in the future that right now we haven't been able to do that hopefully we can do in the future is what's the actual role of the medical student here, right? Because I think that's something that comes up a lot is like, well, I'm like asking questions and I know that's my role, but adding like that other piece in terms of how can we add here that the child can actually be a non-playable character that you can examine, that you can put a stethoscope, so then the medical student will feel more like find their role as a physician in that part of clinical medicine. Not to say that they don't have a part in the social, but they also want that. They want to feel that they are also adding here, because this is more like, oh, we're learning how the social work students and nutrition students are doing this. That's one thing. The other thing is that I think in 10 years, we're probably not going to need the faculty to be in all these simulations, because it's pretty amazing how good the artificial intelligence algorithms are to give feedback, to have a conversation with the students about this, and how then you can just bring the students back and have a conversation and debrief so that you can scale this up. That's another thing. And the last thing, like now that we're thinking about the next step of this in the curriculum, because we were doing this last piece that I show you, every week we had a group of 15 students total that do it in a Thursday. And while we were able to do the whole year, it's just not feasible for us to do that anymore. So we are going to be doing this as part of what we call it the doctoring sessions. So, and this goes back to your question in terms of how do we actually now integrate it formally in the first 2 years. So the doctoring sessions are sessions that happen Tuesday, Wednesday, Thursday in the afternoon. There's 4-hour sessions, but each day we have 8 different groups of 8 medical students. So if we have all the resources, it'll be great if these 8 medical students are wearing their VR headset, 2 social work students are wearing the VR headsets, and the other 2. But if you want to buy 100 headsets, it's expensive. So what we're thinking in doing is that we're actually going to put a TV in these rooms, in the doctoring rooms. So when you're role playing, one of the medical students and the faculty is wearing the headset, and everyone else is accessing the environment through their desktop or through the TV. So they're seeing what happens in the room, but they're not necessarily needing to be there, so they can observe. So there's a lot of interesting things that that can happen. And I think the other thing is that I think is going to change a lot is how much education you need for people to get in this, because there's there's students that just and faculty that go in and they just do it right away, but there's many that don't. But a limitation that we also found is, and I think people were commenting at the beginning, kind of these side effects of VR. And initially the whole thing was 90 minutes, and I could tolerate 90 minutes in the VR, but the evidence shows that 15-20 minutes, that's all you can do. So is the technology going to change so that you are able to support more than that? Yes, I think that's going to change because the headsets are going to be lighter and those things, but I think it's going to take time. So that's why now we've changed that we do a Zoom, then we do VR 15 minutes, we do Zoom again, VR, to try to decrease that cognitive load of the VR thing.
Thank you.
Dr. Casara wrote a question in the chat. So I think he agrees with the challenges with interprofessional education and has a question. Is there a just right number of students for roles? The simulation you showed had 3 for XX minutes. What would be a limit in your opinion?
Yeah, that's a great question. And we decided to have 15 total students because we always had like 8 medical students. If I will have all the resources and all the time, it would be nice to have like the same number of students per profession, right? It'd be nice if, I can collaborate with 3 social work schools, so that we can have 3 social work students, 3 medical students, 3 nutrition students, so that there's not the power dynamic in numbers too. But that's challenging. So now, having said that, in these simulations that we have, even the ones that we had 5 medical students, and from those 5, only 2 did the role play, the others are having a role. So the others, because this is a game, the role of the others is you finish the first role play and you have to give good feedback, because the second game, they need to get a better score. And if you don't give feedback, they're not going to get a better score. So that's a way that you can engage the others, and that has gone really well. But if you don't have that piece, if the others are just looking at it, they're not going to be as engaged. The good thing is that you don't have their phones, their Zoom, their everything. They're engaged because they're wearing the headset, and that helps. But it's a limitation. But I don't think we'll do it for more students that we have now. That would be too much. Also because of how much time it takes to get at least 5 to 10 minutes until people get in and everyone has tested their VR headset and everything there.
Yeah. Other questions? I have another question while we're waiting. So we, like many other schools, have a simulation lab with high fidelity mannequins that we use for clinical skills exams. So I'm just wondering your thoughts on the longevity of that versus replacing that with virtual reality.
Yeah, and that's something that also I actually proposed to do this during COVID, because the medical students couldn't come to do the physical exam practice with the mannequins. And right now, the ability of feel and have this kinetics with the virtual reality it's pretty amazing. Now the technology that can do that is very expensive, that's going to change in a year or two. So everything that we can do in the mannequins in terms of you feeling you know, like an abdominal distension, of you being able to, and things that you can do now is like you can listen to the heart, you can do a lot of things. You can, for example, practice doing a physical exam and moving a leg and doing all those things.
Hello.
All those things can be done. So it's I think it's definitely going to be something that's going to replace. I know nursing is doing a lot of that. Some nursing schools in terms of like replacing their actual kind of mannequin-based simulator labs with VR labs where they go. I think still the limitation is how much time you can be in the VR environment, but that's going to change. So I think at some point is probably going to change. The other thing that could happen is that you're going to have more augmented reality. So you still have the mannequin, but you use headsets to augment things to that mannequin experience. Either, you know, you can dissect it and you can do all these things. So there's a lot of potential. So be interesting to think where it goes.
Yeah. Yeah, I think if we don't have other questions, I'm going to ask the same question that we ask at every single speaker series. And that question is, what, for the audience, what principle from this talk would you apply to our curriculum renewal process? And we can type those answers into the chat. We have avoid cognitive overload when designing educational opportunities that use VR. Willingness to design without borders and use tech to innovate the educational experience. Emphasis on interdisciplinary training, finding ways to create curriculum that bridges learners across sites and disciplines to create a community of learning. Okay, so I guess turning it back to you, Dr. Buitron de la Vega, of all the things that you said today, what do you think we should consider most strongly in our curriculum renewal process?
Yeah, I think in this process, what I've learned is, well, sometimes, you know, I really think that I have an idea of what the students might need or how the students might engage. I think sometimes it falls short in terms of having students be part of the, you know, the table discussions in terms of what they think will be best, because it takes more resources and more time. But this last new simulation that we did was really with a lot more student input, and it was like a big difference. So really having them there. The other thing is, as I mentioned at the beginning, making sure that this enhances your current ideas, your current learning experiences that you have developed, and not necessarily completely replace. Is enhancing, is understanding where the technology fits. So that's something that, for example, in the first pilot with the poverty simulation, we did well, but not in the second one. In the first pilot, we did everything first in paper with a small group to test the cases, because the bulk of this is the cases, and of the poverty simulation is the cases, is the challenges, and we did spend a lot of time making sure that those were vetted by the different students. But in the second one, because of timing, we were not able to vet the case that much, and we had to change it on the fly during the process. So I would always recommend first, before adding the technology, make sure that you're doing a pilot on everything, quote unquote, on paper or on traditional method, and then thinking, how am I going to enhance this? also because many times the technology is going to fail. And if it fails, like I think at the beginning of this, we had like twice that we couldn't run this, but because we initially piloted in Zoom, we just switched to Zoom, and we were able to have a lot of different things. Because you want every student to be exposed to this, so you want to have a safety net for this too. The other thing is that even though we consider a lot at the beginning, is making sure that we consider different experiences of disability from students. What if a student, has issues with being able to be in that environment? How are they going to participate? What if they can not hear well? What if they cannot do all these things? Making sure that you have a way of engaging them in this. And that's why, like in our last survey, we did ask about these side effects. And when we saw that 80% of the students were experiencing side effects with our 60 minutes in VR, we just had to change it to 15 minutes, and now it's going really well. So those things come to mind. And I guess the most challenging thing for me that I would recommend to everyone, if you want to start doing this, make sure that you have a lot of support when you are working with these companies, because they're all well-intentioned, but it's very tricky when you're doing the contract. So make sure that you have a lot of support. Make sure that you take a lot of time making sure that you know exactly what you want to do, what you want them to deliver, because it can get very tricky. And if you had like a amount of money that you had to invest on this, and then suddenly they change their statement of work and those things, it is very hard. So make sure that you had experience. I don't think you need to have experience in gaming to do these things, or VR, or wanting to be like a video game developer as me. I don't think that's necessary. For example, we got a HRSA grant to do a maternal health preventive medicine fellowship, where the team is developing this maternal health rural curriculum, where it's a VR space where the trainees can practice delivering and practice doing this in a rural setting. And all that is being designed by a team that they've never had experience in VR, and they're creating a great product. But it's really about taking time to think how you're going to collaborate with these VR companies, because it's challenging.
Fantastic. Thank you so much. I think that was so fascinating, intriguing. It makes me have a lot to think about. As I mentioned, I'm part of the Curious Questioning Technology team. So we've been looking a lot into virtual reality and AI. So this has been fantastic. I just was going to turn over Dr. Ginsberg. Did you want to share anything? Yes. Okay.
Thank you so much. Yeah, thank you for a terrific talk. And clearly, we all, I think, appreciate all of the work and the effort that's going into designing and creating all this new curriculum on top of, bringing it into a new space and a completely new way of thinking about, delivering curricula. So you're an innovator, and we look forward to looking at what else you develop and how you inspire the rest of us going forward. We are coming, to the end of our Curious Questioning team and our speaker series for our curriculum renewal. So just wanted to share that on May 22nd, we have our next speaker, Dr. Hogue, who's going to be speaking about surgical education, robotics, simulation, and beyond. And then in early June, we are going to be having a town hall to hear a formal report out from all of our Curious Questioning teams about all of the exciting and interesting conversations and discussion they've been having, so that our full community can get a chance to listen, digest, and weigh in. And then we will kind of wrap things up with our summer retreat, which will also be happening in June, along with our final speaker series, which we'll be able to share with you. So thank you for sharing all of your insights with us today, and thank you to the entire team and Dr. Patrizio and our events team and Elizabeth Urbanski from strategy and everybody for being here today to think through this with us. We really appreciate it.
Thank you. Thank you, everybody.
Thank you for inviting me. And if you have any questions, please feel free to reach out.
Will do. Thank you so much.